record on this computer. Alrighty, welcome. It is October 30th, Friday, week 3. Time flies when you're having fun. This is MED260, exams and specialty procedures. What is due today? All week 2 stuff. So what's due today? Your discussion 2, of course. Quiz 2. Don't forget your quizzes. There's quizzes here. You also have a quiz 1 that I put in late that's due this week. I'll do today in theory, but try to get all this stuff done. I'm gonna probably do grading by tomorrow, 12 noon. So after tomorrow, well, probably by tomorrow morning, late protocols will start kicking in. Meaning to say is for every day that goes by, that's 10% off your grade. So late is better than not at all. This week, of course, we have a quiz 3 and a discussion 3, and all who are on this call right now, right? And I'll check again in a while, will get full credit for today's lesson, okay? And if you miss a lesson, please email me. I did the courtesy of emailing you the first week, but if you don't reply, you don't do anything, you get 0 for the lesson. And that's a shame. That's like 30% of your grade. So don't be that person. So what is today's topic? We're now going to get into the medical specialties, and I put some notes in there. Or not notes. What did I thought these were notes. Oh, this is a quiz. Hold up. Yeah, I gotta put in some notes. I also have an old video here, but let's just jump right into the medical specialties. We go into your textbook now. What are medical specialties? When you go to medical school, when you graduate, you have basic surgery and basic medicine, and most people think, like, you know, after that you're done. You can be a doctor. It's not how it works. You have to then apply again for your externship. After you go to your externship, right, then you got to apply again for your residency, and that's when you take all your exams and all that other stuff. Now, your residency is anywhere from 3 to 6 years more of your life. That's why I always tell you guys, if ever you guys want to go to medical school, please speak to me first so I can talk you out of it, because it is a ridiculously long road. And now that I look back on it, I'm like, I can't believe that people actually still want to go through with it. The latest statistics, even during COVID, medical school applications are up 30%, meaning people still want to do this craziness despite the cost. And my mother and I were talking about it the other day, like, why is it out of our whole family of, we've got dozens and dozens of medical professionals, my mother and I were the only lunatics who not only went through medical school, but finished and then practiced. And looking back on it, my mother said the same thing that I did. I'd do it all over again, because it was, I could say it now, it was a hoot. So let's now, medical practices. So here are your clinical practices: infection control, patient interview, is it the other medical specialties? Yep, there it is. So it's chapter 42 in your text, and I will amend those notes. That's like I don't know what I put there. I think I put like a scan of your, what do you call that? The questions at the end. So as usual, in your textbook, everything starts off with a case, and every case that we discuss in any chapter that we discuss is fair game. So we have Valerie Ramirez. Let's say, what's she look? 29-year-old female student, came into her clinic for a follow-up checkup for the removal of a painful wart on her right hand. Okay. During the patient interview, she states that she is not having trouble with her hand. However, she noticed that in the mirror, a lump on the front of her neck now. So it's not only her hand, it's now her neck as well. Now, so the real chief complaint, right, that's iffy. But if you say that it's the wart on the hand, yes, but if we look at their history of present illness, it's really the lesion on her neck, right? And she states she has a little hoarseness, but denies any other symptoms. Notice the language, denies any other symptoms. She could have other symptoms, but at this time when we ask her, she goes, nah, I don't have any. She thought she would tell the doctor. Vital signs look like they're normal. Height 5'2", weight's good. And Dr. Buckwalter is the attending. So orders an ultrasound of the lump with needle biopsy, which is weird. Why would I ultrasound? But hey, that's what they said. I'd biopsy first, right? And what's the biopsy? Most likely fine needle. I take a small needle, I take it out, and then I put the specimen in like a specialized little dish or a specialized a little vial type thing that the needle connects to. And I send that to the Department of Pathology. Another thing that I'm working, and let's see why he ordered TSH and CEA. It doesn't say. So he ordered TSH and CEA, and we're going to talk about, if you recall your medical terminology, you'll know what these are. But I'm not going to say. You should look them up, okay? That's what I'm trying to figure out. Why would he order? But that's what he ordered, okay? So when we're looking at this is a typical medical outpatient case. She's allergic to penicillin, and she lost some weight in the last month. Oh, that's why he's doing a TSH, right? But she claims no diet or no changes in her diet, no changes in her lifestyle, like exercising. She didn't join a gym or anything like that. Okay, so when we're looking at this patient, it's a typical, something that you go see an outpatient. She's not in any real distress, and and she's actually a classic female patient that even for the little things they come in, which is really neat. A male patient could have, a worm growing out of their eyeball, and they still won't come in. So let's look at this real quick. This is like a side note on how to use an epinephrine auto-injector. And we use that for anaphylaxis, which is an emergency allergic reaction, okay? But that's a side note. So what departments could, when you go to outpatient, that she could potentially go see? And what tests that are typically associated with each one? So cardiology, study of heart, right? Of course, cardiovascular systems. Now, the most common are, for imaging and diagnostics, are X-rays and 2D echo, which is echocardiography, and of course your EKG. Now, remember we talked about screening versus a definitive test. A screening test is, we just want to look at, the patient is typically asymptomatic, and we just want to see where they're at. Now, if they fail the screening test, that's when we do a definitive test, something that will define what we definitely have. And remember what I was telling you guys in last week's lecture, that 80% of the diagnosis is the subjective or the patient history. The function of these tests is to confirm things that the doctor kind of already knows. So the EKG or ECG, also known as EKG, electrocardiography, that is a screening test. But the stress test, when they make you run on a treadmill, that is a definitive test for cardiovascular disease. So stress test, when they run, instead of just me yapping, let's show a picture of a stress test. And you could Google a video on what a stress test is. You can see there, we have you hooked up, not only the ECG, sometimes we got you hooked up to a mask and things like that. and we make you walk, and then we record your vitals in real time. This is old school, like every 3 minutes. It's recording in real time. Some places even have video as you're doing it. Then they start increasing the incline, and depending on your physicality, then they start making you run. And I hate stress tests because I'm a runner, so they make me do sprints and stuff, and because it takes a the neat thing about being a runner is it takes a while for your heart to um, really start being stressed out. And the neat thing, it's called elasticity. The neat thing about exercising regularly is that your heart rate will go down to resting rather quickly. And that's a very, very good sign. And also my oxygen demand goes down really fast when they return it back to incline. But my last stress test a year ago was just annoying. And again, because I'm a runner. So here's the thing. The technicians use you there. Oh, by the way, the tech, if it's a high-risk patient, they have already, it's called the cardiac team. They already have the cardiac team on standby. I hate that because like even if the patient's walking, bad can come. Now, a 2D echocardiography, let's look at what that looks like. Echo uses sound, and just like the ultrasound, maybe some of you ladies had one, and we can look at the heart. And another cool thing about 2D echo is you see all these colors. These colors, if you could see here, right, they match up the pressures, and we can record things in real time. And then the cardiologist here can, well, this is the tech most probably, or maybe the cardiologist, right? Because the cardiologists, a lot of them have training in 2D echo. But when we read this, we can look at the video and we can see in real time what's going on and the pressures. But again, we kind of already know from the physical examination what's going on, but the 2D echo gives us a lot of evidence, okay? And of course, x-rays, we do the chest x-ray. Now, the big thing about x-rays is that know your views. Remember AP and PA and LAT, right? It is one of my greatest pet peeves when I ask for a posterior anterior view and I get an AP view back. It's annoying because first, then you have to reschedule, then you have to get the patient back in, then and if it's a high-risk patient, you're putting risk to your patient, and it's just annoying. And do the job right the first time. But x-rays, we get to see enlargement of the heart. We also get to see if there's especially with contrast. Let's show that. We put contrast material via IV. And then we could see some really pretty things. And if you could see here, come on, load already. Are they trolling on me? Oh, there you go. You could see how we could see things. We could even see congestion, and also we can also see some other things. You can easily see the trachea with the cartilaginous rings here, the aortic arch, superior vena cava, right atrium, left ventricle, right ventricle, right? And what's this PA? Oh, that's so this is PA view. CXR stands for chest X-ray, right? So posterior anterior view, meaning the X-ray will go from the back to the front of my patient. So my patient is facing the plate. So, and let's look at a lat view. We also need to look at the heart from the side. Oh, wait, the thing that I was also mentioning, if we use contrast, Oh, here's an interesting one. You can see they got him hooked up to a defibrillator. And it makes sense because we already know that this is my patient's right atrium, right? We already know that's where the SA and AV node is. And if it's damaged, I have a pacemaker hooks up here. This is a huge one. This is probably an old one. The new ones are a lot smaller, probably half the size of that. And you could see the leads that are going into the right atrium. Neat, huh? Well, not neat if you're the patient, but neat if we're looking at it. So that's cardiology, and those are the typical things that you need to know and need to be prepared, and imaging of the heart. And you see here, lifestyle changes, patient education, really, really important. The Department of Dermatology, Dermat, study of skin. Oh, look, another picture of Echo. The big thing about the skin is biopsies and scrapes. They use different kinds of lamps, different kinds of UV lamps and things of that nature. So when you're in if you're assisting in a dermatologic case, or maybe you're in a dermatology office, that's the big thing, biopsies and scrapes. So the protocols that we're going to go over in lab on how to label, how to properly label specimen, and also if it's also for any of these tests, could also be for medical legal, right? So that's very important that you properly label it, and especially if it's medical legal, that there's this form. It's called, what's it called again? I'm having morning dementia. Chain of custody. Oh, thank you, brain. Chain of custody. So if it's a medical legal case, there's a form called the chain of custody form. Every person who ever touches or gets involved with that specimen has to sign off on that form. So you make sure that the specimen and the form get properly endorsed to the next person. Because if it's used for evidence in court, someone's going to ask, okay, who are the 3 people who touched it? How many people who touched the specimen? If more people touches the specimen, it could be grounds for contamination, that kind of thing. Endocrinology. The big thing about endocrinology is hormones. So the big thing is blood tests. Okay. Once you get through your phlebotomy, know your tubes, and again, know your labeling. And we're going to be talking a little bit more in the weeks to come, what specific tests. But endocrinology, the big thing, it's almost always blood tests. Now that we're talking about endocrinology, I want to also remind you that the big endocrinology thing is always diabetes. So let's talk about diabetes mellitus. Now, remember the screening test? That's for an asymptomatic patient. So the screening test that we do is FBS, also known as FBG, which is fasting blood sugar or fasting blood glucose. Fasting has to be done at least 10 hours. So no food, only water. Always say water, water, water. And this is a trick that I have. I always tell the patient to drink 5 glasses of water before they come in. Now, you're gonna get complaints. They're gonna go, 5 glasses? I can't drink 5. Because if you say 1, what's gonna happen? They're gonna take a sip of water, and then they're gonna come in. They won't be able to give you specimen. It's classic. But if you say 5 glasses, they'll get to half a glass or 1 glass. And when you tell them fasting, make sure to tell them, try to get these fasting tests in the morning, because you don't want to be the person I remember one time, because I had to lecture in the morning, I took an FBG at 1:30 in the afternoon. That means I couldn't eat breakfast or lunch. Don't do that to your patient. I was loopy as all heck by the time I got to my doctor's office. And of course, my fasting blood sugar and my fasting blood glucose was abnormal, right? And, you know, in the future, especially nursing, you're going to be talking about specific numbers. But for this class, very, very simple. FBS, FBG is a screening, and the fasting should be at least for 10 hours. Now, if this person fails this, that means their sugar is too high. It either means there was non-compliance, they actually ate something. And even if it's just a sip of orange juice, it could mess it up. Then we must order a definitive test. The definitive test for diabetes mellitus is OGTT, oral glucose tolerance test. Okay, and maybe some of you ladies had it to diagnose gestational diabetes when you had your children. And what's the OGTT for us non-pregnant people and people who didn't have this even when it's a nice little video. All right.
Insulin injections can make diabetes complicated. Omnipod delivers insulin through a discreet waterproof pod.
Okay.
Hello. Today we will talk about glucose tolerance test. What is this test? Why is it done? How is it done? About this, some basic information I shall give you. What is glucose tolerance test? This test measures the ability of the body to handle a given amount of glucose which is given to it in a fasting state. What are the uses of glucose tolerance test? The main use of this test is in detecting gestational diabetes. It is a gold standard for its diagnosis. Apart from this, it can differentiate between a pre-diabetic.
You're gonna get that word a lot for definitive tests. They always say things like gold standard.
And a diabetic patient. How is this test done? For this test, the patient has to arrive in the lab in a fasting state. At least 8 hours fasting is required. The patient can have plain water, but no other beverage should be taken. After that, a fasting sample is withdrawn. Then a patient is given a given amount of glucose depending upon the weight of the patient. For a standard 60 kg weight patient, 75 grams of glucose is given.
Right? So that nasty, super sweet syrup that they have in this little bottle, it's done, it should be done in theory based on your weight.
After that, the samples are collected at 1 hour and 2 hours. Is there any special instruction that is given before the test? As I have mentioned, the patient should come for the test in a fasting state. At least 8 hours fasting is required. For detecting gestational diabetes, this test should be performed between 24 to 28 weeks of gestation. For other patients,
and that's based on your typical 40 weeks age of gestation, or AOG, for your pregnant mommy. So it's around midpoint.
It can be done at any time. If the patient is on medication like steroids, beta blockers, etc., these should be stopped for at least 2 days before the test. Is this test painful?
Okay, that should be enough. Bet you anything she's a senior resident. Look at those eye bags. She looks tired. Ugh, give me flashbacks. So that is the OGTT. It is the gold standard. It is the definitive test for diabetes and gestational diabetes. And it not only can tell you if you have diabetes, it can also tell you if you have pre-diabetes. Nowadays, we're so specific regarding diabetes and so specific about prevention. Pre-diabetes is a big thing. I've had it for like the last 2 years, and it's nice because it's warning you, you're on your way, you have to go fix things. And the number one fix, the number one management is, of course, lifestyle changes. So in the last 2 years, what have I done? I'm eliminating white rice out of my diet, which is really rough because I'm Asian. Asians, all they do is eat white rice, the sticky white rice, which, by the way, is the worst rice to eat, but it's so tasty. There's something called the glycemic index. It's a 0 to 100, and the glycemic index is an indices that talk about you know, how much sugar there is in food. Table sugar is around 65, 70 in the glycemic index. White rice, you know, Asian basmati rice, holy crow, the score is 100, sometimes 110. And you imagine I've been eating that a cup a day, at least a cup or 2 cups of rice of this stuff every day since I was a kid, usually mixed with bacon and Doritos. So is it any surprise that I'm pre-diabetic in my older age? But it's a nice warning. Another test that endocrinology love to do is glycosylated hemoglobin. Okay, now glycosylated hemoglobin, also known as HbA1c. Maybe you've seen it. Glycosylated hemoglobin. Now, if you remember your medical terminology powers, hemoglobin, hemo means blood, globin means protein. And remember on the red blood cell, the middle of the red blood cell was kind of, has no nucleus and it's kind of faint. Well, in the middle of our red blood cells is hemoglobin. And hemoglobin carries oxygen, carbon dioxide, and a whole bunch of other things. And one of the things that it carries is sugar, glucose. Now, the A1C tells you, it tells you your glycemic load, right? Your glucose load for the last 90 days, right? That's rough. That's how your endocrinologist slash internist knows that you're a liar, right? How many times I always say to my endocrinologist, he goes, "Oh, Dr. Miyazaki, I've been really good. I've been doing my workouts and I've been avoiding white rice." And then she looks at my A1C and then it's what? It's garbage, right? And it tells her right off the bat, he hasn't been really on his diet. He has been touching white rice, and goes, and it's a problem. So the A1C and the OGTT, you put those things together, it can paint a wonderful picture of a pre-diabetic to diabetic patient. And also, these two tests together tell us how bad the diabetes is, right? How bad is our body at taking the glucose and putting it inside the cell. And if it doesn't put it inside the cell, remember my analogy, it's like putting gasoline on the seats of your car and on the hood of your car. It's not going to do any good, and it's going to do a lot of bad things. GI or GE, gastroenterology, that was when I was a resident, that was my thing. I wanted to be GI, wanted to be in GI med. And the big thing that they do is scoping, right? Endoscopy. Now, you could have endoscopy is either upper GI series or lower GI series. And let's look at GI anatomy. So when I look at the anatomy, right? Well, maybe this is a little better to look at. If you're looking at patient's anatomy, if it would let me, there you go. Okay. I could scope you. I could stick a tube down here, okay? And I could go through your stomach, and from your stomach, and probably scope you to like this level, okay? Which is the first part of the, this is your duodenum, which is the first part of your small intestine. So an upper GI series would be anything that from here down here. Now a lower GI series, right, is from anywhere from the anus, I can stick a tube, and then I could tube you that way. So that's the main things that we do in GI Med, and we could diagnose a whole bunch of things. We can actually even do via endoscopy, like some biopsies and even some basic surgeries. Okay, so upper GI, I want you to think the level of the stomach on up. Lower GI series, level of the small intestine or the duodenum on down. Now, what's a colonoscopy? Colonoscopy focuses on your rectum here for any rectal CA or rectal cancer, the sigmoid up, the descending part of your colon, and then we're going to look at the splenic flexure here, right, because it's near the spleen, and we're going to look at the hepatic flexure that's near your liver here, and then down here, and this is your lovely appendix. Another thing with GI Med that we really love to do a lot is ultrasound, because it's non-invasive and I don't have to go through surgery, and it won't traumatize my patient too much. All right, and that's GE or GI Med, okay? Department of Neurology, they have a lot of really neat toys and modalities, and from CT scan, MRI, EEG. Now, the one that's specific to neurology is electroencephalogram. Let's look at a picture of that. They hook you up, and this is also utilized in sleep studies, because remember, your brain runs on, your brain communicates with the rest of your body through through a very small electrical impulses. And then we put these clips all around your head. It's like a bonnet that you get to wear, and it's got all these little electrodes. Now, it doesn't hurt. It just makes you look strange. And we use this for either people with sleep disorders, or and we really use this stuff for people who have seizure disorders, because we can actually diagnose the type of seizures, and also the type of if the sleep disorder is partially neurologic. Oh, look, looks like one of my kids, little baby. Get to tape that stuff on their head. Oh boy, that's no bueno. Oh, they tried doing this, and of course it's in CBS News. Remember, autism is well, I'm not going to get into it now, but this is not efficacious. I read this study more than 5 years ago. You know, then when it gets on the news, it's already autistic patients have nominal EEG findings, but you know, we always got to look. So if you look at the EEG, there's just like your EKG, there's specific little waves and spindles, and when you sleep, it has increased activity. That's why I always state, if you what do you call that? It goes before an exam, you should really get a good night's sleep. And actually, you should try to always get a good night's sleep, even though you're in the healthcare field, because the only time that your brain processes things is when it's asleep. When you're awake, it's on record, it's taking in things. But you remember, your brain has to process things so that later when you take the exam, you get to retrieve it. And doing all-nighters is not the answer. It'll actually do damage. You'll lose memory if you pull all-nighters. It's not advisable. Okay. Let's look at now CT scan. What does a CT scan do? And you can see here, CT scan, and this is for GI and back, so we could look at for a whole thing. So what's the function is, and let's do CT scan brain. It's this big machine, and now we have open ones because it gets a little bit claustrophobic when this thing comes in. And last time I had a CT scan, I was really young. It was very, I don't know, I got creeped out when they did it to me. So CT scan of your brain. Let's look at it. You can see what it does. CT scan is X-rays, but an X-ray only takes one shot. A CT scan takes a serial number of shots. It takes several shots, and then it shows different levels in real time, and so that the neurologist can look at the anatomy and to see if there's something up. Let's find something with see how there's an anomaly there, right? Something wrong, right? And you could see, now what's the difference between a CT and an MRI? The CT scan uses X-rays, right? And then the computer takes that X-ray data and then creates an image. Then MRI uses magnets, uses magnetism. Because remember, we learned that our bodies are made out of pluses and minuses, right? Well, the fluid in our bodies and all of our cavities and everything and all of our tissue, they're also made out of ions and pluses and minuses. And the magnetic resonance imaging, it sends a signal, and it makes the pluses and minuses bounce back and forth, and then it makes us a picture. So MRI, I want you to think magnets, CT, X-rays, okay? And not only neurology uses it, but a whole bunch of other departments use CT and MRI. But CT and MRI is big on the skull in the Department of Neurology. Oncology, onc, study of tumors. So what does oncology do? They deal with cancer, okay? Whether it's benign or malignant, they're the ones who are going to not only diagnose you. So they work very closely with pathology. Pathology gets to tell them, what the samples look like, but it's oncology that has to now figure out what's the management. What do we have to do? And one of the big things that the Department of Oncology do is they grade the tumor. Maybe you've heard of like stage 3, stage 2, or whatever regarding the tumors, whether it be benign or malignant, because it's very important to grade the tumor properly, not only for diagnostic purposes, but for management purposes. Because grade 1, I'm not going to handle it like a grade 4. Grade 4 is bad. Grade 4 means that it's most likely malignant and it's already metastasizing. Metastasis is when the tumor, most likely malignant, moved from one place to another place. So that's no bueno. That means you have more cells that are photocopying themselves in your body, and they're not doing anything for you. These cells just eat up energy and also cause a whole bunch of trouble. Benign neoplasms or benign cancers, those are better, and they're better managed because they tend not to move around, and they tend not to grow very fast. But malignant tumors grow very fast, and they tend to metastasize. So grading the tumor is a very big part of the diagnosis of oncology, and also a very big part on the management. So when you have cancer, these are the people you go to. And they even have subspecialties. Oh, looky here, another EEG. And this could also be a sleep study. They put you in the room, and then they videotape you and how you sleep, and then in real time they look at your EEG. Ooh, this is a color one too, and it's mapping out the waves and where's the activity. Did I tell you guys I went? I probably told you guys already, so bear with me. My mother and I went to, about 10 years ago, went to a symposium looking at the CTs and MRIs and EEG and neurologic and psychiatric profiles of known serial killers. And they found out when they did the CTs and MRIs that these really, really dangerous people have no significant difference between you and I. So that's something to fuel your fears on this Halloween weekend. So let's see. Here's different kinds of cancers, and here is what they call the triple therapy. I mean, you don't need to memorize this stuff, but the one takeaway from this particular table is oncology also has to deal with other departments, because typically for a malignant tumor, there's something called triple therapy. You not only have to have surgery, so oncology has to talk to surgery. You not only have to have radiotherapy or radiation therapy, so you have to talk to the diagnostic and imaging people. You have to talk to the radiologist, because this is when we take actual radiation and we zap your tumor with radiation, right? It seems counterintuitive. It seems like, oh my God, isn't radiation what got me the cancer? Isn't radiation gonna get me sick? And the answer is yes. And last but not least, chemotherapy, right? We introduce chemicals. The oncologist has to introduce chemicals into my patient to go kill the tumor. So these things, you do them all together. And you can see how hardcore this is, and especially in a more advanced case or a patient who has comorbidities or is advanced in age. So that's triple therapy, and that's a wonderful all of the above question, isn't it? Surgery, radiation, and chemotherapy for your more malignant, not disease, your more malignant tumors. Okay? And the oncologist, they're the person who figures out that balance. Okay. Orthopedics. When I was a medical assistant, I served a couple of years in the Department of Orthopedics. And what do? They are a surgical service. So their big thing is pre-admission testing and x-rays. Okay? So you're going to be dealing with x-rays. And again, I have to reiterate, the big thing on x-rays, oh, heavens to mercy, my baby's awake. Not good. The big thing on x-rays is the view, okay? Right leg versus left leg. Is it anterior? Is it posterior? No, you can leave that. Leave that. That's clean. So another casting, and you may or may not help. But the big thing is scheduling for the surgeries and the x-rays. That's the big thing you do in orthopedics. Sometimes I used to help with the casting, usually was the nurse, but that was years ago. Maybe you do that now. And other therapy regimens. But the big thing in orthopedics is these x-rays. What diseases? Nice to know. May or may not ask them, but it's nice to know. You could look at them. Common dermatologic, because remember, this is not a pathology class, so we only want to talk about glucose monitoring for FBS, right? Fasting blood sugar. Let's talk about that. And this is a Lancet pen. Let's look at a nice video. So a glucometer or glucometer. So diabetics and even pre-diabetics, depending on how bad your pre-diabetes is, you have to check your blood sugar. And of course, fasting, right? At least 8 hours. I like 10, right? So this is how you check your blood sugar. And I like this lady's video.
Hey everyone, it's Sarah with registerednursern.com. And in this video, we're gonna go over how to check your blood sugar. As a nursing student, you're going to have to learn the skill of how to check a blood glucose using a glucometer. As a nurse working in the hospital setting, you will be checking your patients' glucoses, especially your diabetic patients. Now, if you're watching this video because you've been newly diagnosed as a diabetic, or you've been experiencing bouts of hypoglycemia, meaning your blood sugar drops, and you bought a glucometer just to monitor your blood sugar, this video will help you how to do that, because I'm actually going to show you myself of taking a blood sugar, how to do it. And I'm going to go over all the supplies with you. Now, check out my other videos on how to do a quality control test on your glucometer, how to poke your finger with a Lancet, and how to load your Lancet device if you're confused on any of those things. So let's get started. This is a basic home glucometer testing kit that you can get. Now, nursing students, your glucometer in the hospital will probably look a little bit differently, but they all work the same. Now, if you were newly diagnosed with diabetes and you need some advice on getting a kit, I really recommend that for your first kit that you get a kit that comes with a meter, comes with test strips, a quality control, your Lancet device, and your little Lancets, because this will help you when you're first starting out, and it'll have everything you need. And they usually come with a little carrying case, a little book log, and you can have all your extra supplies. So let's go over what's in this kit. First thing you have are your testing strips. Each monitor comes with a specific testing strip. So when you run out of testing strips, you have to buy the test strips that go along with the monitor. And please note, this is so important. Once you open up these test strips, they're only good for 4 months, okay? So right on the bottle when you open them, and they're only good for 4 months. And make sure you check the expiration date when you buy them to make sure that they aren't expired, because if you use expired test strips, you'll get wrong readings. And your test strips look like this.
Oh, by the way, we tested that in lab a couple years ago. It still kind of worked. We were using stuff from like years ago, and in our small class of 4 people. But again, you cannot use expired. But if that's all you got, even if it's expired maybe a month, make sure you note it down. And why is she wearing this huge ring? That's a no-go in the lab. But hey, you know, she's got to look pretty for the video.
This part will go into the monitor, and then this part will collect your sample, and we'll go over that here in a second.
And there are arrows
next
on those
we
things
have
to tell
the
you which
meter
direction.
itself, so small but it's very handy. They've came a long way. They used to be very big. Usually you can hit the on button right here, whatever your monitor says. Always read your glucometer monitor settings, because they all work a little bit differently. But this one works. You can hit this button right here, or just put in the test strip and it comes on itself. We have our quality control. You'll always want to get some type of quality control testing, because when you first get your monitor, you want to do a quality control test just to make sure it's calibrated right.
Okay, that's called QC, or quality control. There's a form in the doctor's office on who did it, when they do it, and you have to perform that regularly. So if you know you got like a whole bunch of diabetic patients coming in or scheduled, one of the things that you do when you come in the morning is you make sure all the gear is calibrated, and this is one of the machines that you have to check. And there's usually a logbook somewhere.
Then you'll want to perform it, you know, every other couple days, and especially when you change out your strips. And another thing that is important to know, this solution is only good for 3 months from the time you open it, and it expires after that. So keep that in mind. Next, what we have is a Lancet device. You will need this so you can actually poke your finger. What you do is you unscrew that, you load the Lancet in there, and you engage it, and then you poke your finger, and we'll go over exactly those steps on how to do that here in a second. Next, you have your Lancets. These right here are 30 gauge, and I just want to show you the different gauges. You can get various gauges of Lancets. You can get 27, 28, 30, 32, and 33. Basically, what it is, it's the size of the needle, and a 30 gauge is usually sufficient enough. The lower the number, the bigger the needle. So if you have really thick skin.
That also goes the same for, you know, the bigger needles. So it's backwards, like the bigger the number, the smaller the needle. The smaller the number, the bigger the needle.
You might want to go with a bigger gauge, but usually 30 is sufficient enough for people. And then this is just a little test log. A lot of monitors are fancy and they'll keep it stored in as a memory and your doctor can just upload.
Yeah, I wouldn't trust that because all it takes is for like the battery casing to pop out or something to happen. It loses your entire log. It's in your best interest to write it down somewhere and record it down somewhere. And your logbook has to have a signature on who actually did it, which is this machine can't do that.
This one is just basic, and you want to record what your blood sugar is so you can keep track of it, take it to the doctor with you, so they'll be able to see what your blood sugars have been reading. So now, and also some alcohol prep that you want to clean your fingers with. So now let's get ready and check our blood sugar. The very first thing you want to do before you check your blood sugar is wash your hands with warm water, because that's what.
All right, see this? That's also a no-go in any lab. They're too long. She's a nurse. She knows better.
Increase the blood flow to your fingertips, because when you check your blood sugar, the best place generally is to check on the fingertips. Some devices say you can use your forearm, your palm, but this device specifically recommends fingertips.
All right, fingertips. Which ones? You're always going to shoot for your third or fourth finger, and you're going to always shoot for the sides. You don't want to shoot in the middle, because that's where you have a lot of nerve endings. It's painful there. And you don't want to shoot in your thumb. There's way too much tissue fluid. You don't want to shoot in your pinky because there's not enough tissue fluid. So it's third and fourth finger. And you definitely don't want to shoot or poke in your second digit or your pointer finger, because that's the finger you use the most. So even if you do a prick on the sides of those fingers, it's painful. So always third and fourth digit. I always use the non-dominant hand of my patient if I can, right? And those are the places, third and fourth digit on the sides of the pad, on the finger pad. So it's like here, like on the sides of the finger.
After you wash your hands, you're going to get your supplies. And what I like to do is get everything set up. So very first thing, it doesn't really matter what order you do it in, just as long as you do it. We are going to prime our...
Wrong, it matters. All orders, the order of your protocol always matters. Man, I should make my own video.
Lancet device. So in order to do that, Lancet devices look a little bit differently, but they work the same. They generally twist off right here.
Insulin injections can make diabetes complicated. Meet Omnipod. It delivers insulin through a tubeless pod.
No, thank you.
And you're going to take the cap off, and this is where your Lancet is going to go. Your Lancet typically has these little grooves around it, and it will fit snugly inside this part. Now, I just want to show you something. Whenever you push this part in, notice it engages the needle. Now, whenever you're ready to poke your finger, you're going to hit this button. And when you hit this button like that, it takes the needle and pokes it in your finger. So what we want to do is just get that Lancet inside the device and line it up with these grooves and just push it in snugly. And we're going to go ahead and engage that. And now we need to expose the needle. The needle's been protected by this little area right here. So what you do is just simply twist it off.
Hey, where's your gloves? Also, nice little thing to note. We're dealing with blood here. Even though it's a tiny speck of blood, it's still blood, never the same. That's why we call it universal precautions, right? What we do for one patient, we do for all patients. And now she's touching the sides of the needle and the sides of this with bare hands, right? That's a no-go.
And if you can see right there, it's exposing your needle. Now we're going to put the cap back on, and we're going to just twist this on right here. And we are almost ready to go, but if you notice, can you see these little numbers right here on the device? This is how deep the needle is going to go into your finger to draw blood. So here's generally the rule. You'll want to read the instructions on your Lancet device, but typically you want to use a 1 to 2 setting if you have really thin skin, a 3 to 4 setting if you have just average skin, and a 5 or 6 setting if you have thick callous skin. So what I like to say is 1 to 2, if you know, women, we tend to have thin skin. If you're on corticosteroids or your hands bruise easily, probably 1 to 2 is sufficient enough. 3 to 4, typically young people have a lot of collagen in their skin. It's average thickness. 3 to 4 is good. But if you're a man who works a lot with your hands, even women, and you have calloused hands, a 5 or 6 is definitely where you want to go, because you want to be able to draw enough blood in one stick. So here
okay. So yes, all of that is viable. And of course you gauge it, but you could see how complex all of this is, and it's got a lot of prep. How's this? I take the Lancet, I take it out, and I just poke your finger, and I move on with my day. We'll train you with these things, but me personally, I just take the Lancet with a gloved hand, of course. I ask the patient to look away, and then I just poke them, right? And then I just use, my feel, because if it's like if she has lady hands, and if your patient is very thin skinned, and then I'm not gonna press as hard. But if it's like some guy who, who works the docks and lays cable down for a living, of course is gonna have nice, thick, rough hands. So I'm going to poke a little deeper. I personally don't like these things. It's all complex. It's all a lot of hullabaloo just to take a needle just to poke you. And also, there's a lot of point source for contamination with all that stuff.
I'm just going to slide mine to a 3 because that's efficient enough on me. Okay, so we have our Lancet device ready, and we can't hit this button yet because remember the needle will go off. So we're just going to set that aside. Now we're going to get out our test.
You could see where if you forgot to cock the device or push it down, or if you bump into that button, how it's going to mess everything up, and then you have to open it all back up again, increasing your level of point source.
Strips. And remember, these were good for how long? 4 months. And what we're going to do.
So many things. I should have screened this video before. I used this video before, but I'm being picky today. Do you see how she dug her dirty hands into there? Your hands have oil and things on it, and it might ruin this thing. So how I was trained is, you see this nice, it's not necessarily sterile, but this area right here, I kind of like dump it out little by little by little until, like pixie sticks, until 1 or 2 of them kind of stick out. And then I use my gloved hand to remove just one. And then I close it back up. Remember to close it back up because these things are photosensitive. So if you leave them out, and even in the light of your office, you could ruin them. I found out the hard way.
Look at the test strip. Always read your device's instruction, but on this device.
Do you see how she's manhandling on this? And especially if you got gloves, try not to. This is the part that's going to fit into the computer part. It's going to look like a computer chip, and then there's typically an arrow with like a red drop of blood or a printed drop of blood in the area. You don't want to touch the testing area. And you can see her hands are all over this testing area right here. That's a no-go.
This part goes into the monitor, okay? And then this little part is where it's going to actually suck up the blood sample. So what we're going to do is we're going to slide it into this part of the monitor, and it'll turn the monitor on for us. Okay, see how it did that? Okay, now we are ready to poke our finger and see what our blood sugar is.
And typically the machines, especially the new ones, tell you exactly what to do. But it's at this point, like, even if this thing has an on-off button, don't mess with it. Don't mess with this button. Just put the test strip in, and you'll also know which way to put the test strip in. There'll be little signs and little things, so you know which way is up.
So what we're gonna do, you want to clean the finger off with some alcohol prep. So, and massage on your finger, because this is getting all the blood flow to your fingertip. And you're gonna use the pad of your fingers, and we're gonna go right on.
And that is called milking the digits, your digits. When we milking, you're trying to increase blood flow within that area so that the blood will come out.
Side of the finger, okay? Not in the middle, but on the side. That's typically where those little capillaries are, and you get a really good blood draw from that. So I'm massaging on that. I'm gonna clean the area with alcohol, let it dry.
Oh, by the way, why is she doing it on top of this thing? Right? This thing isn't sterile. At least if I have my chucks or my absorbent pad out, it's cleaner than this thing. So, and again, right, I'm being all nitpicky, but we'll see all of this in laboratory.
Thoroughly. Now, after I poke.
That's another thing. When you clean this off with 70% isopropyl alcohol, when you clean it from proximal to distal. So when I clean this finger, when I don't rub it back and forth. I take it and I rub it out, so that any garbage that's here, or Staphylococcus aureus or Staph epidermidis, everything will go where? Out in one direction. I'm not digging things into the pores of my skin.
The needle into my finger, I'm gonna wipe off that first drop of blood, because there's still some alcohol in it, and it could dilute the little specimen that you're giving the monitor and throw off your read.
Well, that's partial of the reason. You wipe off the first set of blood because, number one, it has tissue fluid. Number two, it could have some alcohol from your skin, right? But you shouldn't poke when the skin is wet. And also, number three, remember, it's just 70% isopropyl alcohol. That's just the disinfectant. There's still bacteria on there. So you just want to, just to make sure, just to wipe off the rest, just to brush it by and just wipe off the first blood that you see.
So always remember to do that. Okay. So what we're going to do is I'm going to line it up, and you're going to see a small drop of blood. So if you're squeamish with blood, you might want to not watch this part. And get my first sample, and I'm going to wipe that off, and then I'm just going to squeeze a little bit more. You don't really have to squeeze too hard. It gets enough.
Sometimes you do.
Size drop. And then you're going to put it on the end of the monitor like that, and it sucks it up very. Now
that's called capillary refill, right? Or not capillary refill, capillary filling, because all intents and purposes, this is a very mini capillary tube, and it's just gonna draw up all that blood by itself.
And we're gonna see what the reading is, and then hold pressure where you poked your finger. I think
so you saw it was 85. Typically, a normal FBS is from, like, if I remember my numbers right, 95 to 103. Greater than 103 milligrams per deciliter for a fasting patient is pre-diabetes. Anything above 110 or 115, your patient, odds are, is diabetic, or something seriously is going wrong. So that's a main thing we're going to be doing in lab, and I just wanted to show you that. And because diabetes is a big thing, and taking this is a very, very important thing, and knowing the ins and outs of how to do this. Another thing I also don't like is, you see this? Is this thing sterile? No, it could have contaminants of the last person who you poked, right? So, me personally, I don't like using. I don't like using that needle thing. Exams, we already talked. Oh, allergy testing. That's for allergology. Also, who else does a lot of allergy testing? The Department of Dermatology. So these are the tests. One test is a scratch test. We put the suspected allergen on a needle, and we scratch you. And then we look at if there's any inflammation or any reaction within 24 hours, okay? The next is an intradermal test, right? It's a little deeper, and we kind of inject a liquid version of the allergen into your upper layers of your skin using one of those tuberculosis needles. So let me show you what that looks like. You take one of these needles. We use them for TB testing, and we also use it for the orange tops. We use this for insulin. But this is what you are creating when you just put it. See, right? You're gonna create just where's a good one? Here you go. You just want to create a bump, right? And that's gonna have the allergen in it. Now, then we wait like 24 hours, and then if it expands to this, right, or something like this, and guess what? You're allergic. Patch test, we use these patches. We like placing them in different areas. One of them is the volar surface of your arm, this part of your forearm. That's VOLAR. And another place that we put here, and we number them. Another place we put here is in your interscapular area of your back. We also do the same thing for scratch tests. We also do the same thing for the intradermal test. These are common areas where we test for allergic reactions. And also, we're very much aware that even these small amounts can cause anaphylaxis. Anaphylaxis is an extreme allergic reaction, and that's where your EpiPen comes in. Last but not least, we do RAST, right? We want to check your blood levels for antibodies, because if you're allergic to like pet dander, you're going to have a lot of pet dander antibodies and specific allergens. Also, your white blood count, when you do your white blood cell count and your differential, we're going to look at the different white blood cells, and those will increase. Another thing that dermatology and allergology will also start looking at is your IgE, IgA. Those are your immunoglobulins. They have IgA, IgD, IgG, a whole bunch of IGs. But IG stands for immunoglobulins. And globulin, we already know, is proteins. If you have a lot of antibodies, if you have some sort of allergic reaction, you're going to have a lot of immune products, more than usual, in the plasma of your blood. And we could look at it that way. And a RAST is one of those types of tests. Okay, we ready? Ooh, we saw that picture before. This is a Holter monitor. They're much smaller now. Now there's apps for your phone, and they're wireless now. Nowadays, you can Google that stuff, but it'll pretty much it's an EKG device, but it sends it to the Department of Telemetry. And the patient is supposed to keep like a diary for like 24 to 48 hours on what they were doing while their Holter monitor was on. Because remember, cardiomyopathies and cardiology problems tend to surface when your heart is stressed out. Hence, the theory behind stress tests. So if you're walking around or you're at work or things of that matter, and you record what your activities were, and then the Holter monitor in real time will start, we'll of course record that, and then you get to talk to the cardiologist on, how they coincide with your activities during the recorded time. Ooh, another thing I forgot to mention about cardiology, angiogram. Angiography, well, I did mention it in a way. It's that X-ray contrast stuff. We put in fluoroscopy, we put these chemicals via your veins, via IV, and then we take X-rays of your chest, and it makes all the coronary arteries pop out. Let's look at a pretty picture. See So when we take an x-ray, you can see all the blood vessels. This is, I believe this is a brain. Here you can see the circle of Willis. I could be wrong. This definitely is heart. This is your coronary arteries. And you could see if there was a problem. Like, this doesn't look good. I don't know what this is. Right? It could be a bleed. But you could see if there's a blockage or stenosis, we'll definitely see it. Okay? Dermatology. Oh, remember I told you the different types of light? There's a ultraviolet light, and it's called Wood's light. And we could, that's how we know where to scrape your skin. Endocrine test, we already talked about. GI, we already talked about endoscopy, colonoscopy, sigmoidoscopy. Here, scope. But these things now are connected to a TV camera. And it's really neat because I can not only record it, or I could stream it live, and another expert or my boss can see if I'm doing something correct. Gallbladder function test, cholecystography, right? Other things, HIDA-scan, I could do the same thing with ultrasound. Now, what's a barium swallow? In order to make your GI look more definitive in an X-ray, I give you barium to swallow, and then it makes everything glow. So if I could see, ooh, looky here, right? If on this is an AP view, anterior posterior view, and this is a lat, and you could see, ooh, looky here, something's up here. There's also a potential lesion here and some stricture here. See, you could see certain things. Right? Ooh, this one's even worse. See that? Look at that. That's definitely stenosis. And then I have some sort of blockage here. Then it opens all the way up here. Right? And we can also do the same thing on the other end of your GI, and that's called a barium enema. So I shoot water with barium in it up your rectum, and then I can see things that way as well. We talked about that. We talked about that. MRI, we talked about that. Oncology, the big thing is biopsy. CEA, carcinoembryonic antigen, or cancer markers. Blood tests, cancers, since they're abnormal cells, they're going to exhibit abnormal chemistry. And sometimes they're going to also exhibit abnormal chemical communication within your body. They're going to act just like your normal cells, but they're going to just act weird. And we use CEA and the other cancer markers like CA125 and BRCA. Maybe you've heard of BRCA's, BRCA for breast carcinoma. Right? We use all those. We can find those in their blood. That's how Angelina Jolie knew, not only because of her family history, she lit up for all 4 BRCA markers. So she had a double mastectomy because she didn't, and just smart move because if you know it's coming, might as well just remove the breast tissue. And if you don't have any breast tissue, you can't have breast cancer. We talked about that. We talked about that. You can also scope in orthopedics. You could scope also the joint spaces. I've done through this. It looks painful, but it's far less painful than actual surgery and opening your knee up. This is really neat, and I'm gonna have to go through this soon for my knees. All right, and that's it. Wow, record. Now I'm going to. What am I doing? What am I doing? It's not what I do. Okay. Where's my recording? Stop.